time the computer gets activated, I hope you enjoyed the live surgery. And there is an enigma that doing live surgeries, it's like you spend more time with the robots. Actually, it has fastened everything, especially in these. You'll see tomorrow that we have so much planned and dedicated that things go fast. Anyways, I'll try to be fast in this presentation. So I think we are here. So can I have anything? Okay, I'll proceed. Anyways, our experience with robotic arm technology. So thank you, Bihar Orthopedic Association, for getting this conference held under their banner, and how robot has increased my accuracy. So basically, I should disclose I receive royalties from Stryker, but not for this. What we aim in arthroplasty is accuracy, confidence and reproducibility, and of course flexibility. And at Anup Institute, we are quite far ahead because we have the robotic arm in action. So what has changed my practice over the time? I have changed in my perspective, targets of implant positioning, surgical processes. We do less harm to the soft tissues and make processes faster than normal. And we have enhanced recovery protocols. So we have so many things in the market and really don't know what all we should buy if we aim to buy something. And with new technology comes newer concepts. The concept of functional alignment. But what one thing which I'd like to highlight here is prior to the navigation and robotic technology, we used to plan, then cut. Let us take the example of a knee replacement. We used to plan, cut, then balance, then assess and balance. Now we plan, we assess the laxity, we balance first and then cut accordingly. So chances of getting things wrong are lesser. Now, robotic workflow has new concepts of functional alignment and predictive gap balancing. These are absolutely new concepts, and it can be done only with the help of either navigation or robotics. But yes, we should all have an understanding of all these accesses. So there are so many things. I told you 54 cup, we did 54 today. It was at an angle of 44 degrees. It was an inclination of version of 18 degrees. We can't see 18 degrees by eyes. Same with knees. We can upsize, downsize. I can see the robot's X-rays done by the robotic arm, and I can say that it has been performed by a robotic arm because there is no mismatch in the implants. So some cases worth reviewing, which we should understand. So these are some pretty cases, like these are the cases which generally I handle, and all these cases are. So we have all technologies at our hospital, navigation, handled and enforced control robots, and obviously our brains. But each things are important in one particular situation. So let us say, for example, this case. Now, if you have a look at this case, this was primarily planned by the robotic arm, and you can see fibrous union, non-union, and all those things. If I get back to the CT scan, so it's rolling down, but you can see there was a posteromedial fragment, and so we got it planned. Each of our plan is segmented in Florida, America, and then we get a plan. So the Americans said, no, it can't be done. So fine, we thought, okay, we'll try the registration. So this was the plan which was given by them. So this was some idea preoperatively that what we are going to do. So we try to register it. Because if you can't pass the registration, you can't be on the robotic platform. But patient wants surgery. So we registered and we managed to get it 0.5 within the accuracy range. So we then got everything on the digital platform. We got the balances. We did everything without any disturbance in the proximal, without any problems in the proximal tibial cut. We had a joint line evaluation and we had robotic arm to our help. Of course, the proximal posteromedial fragment was quite fibrosis was there, so it got detached, so we just plated it. And this is what we did it post-operatively. So patient was mobilized the next day, 4 hours, and this is after serial follow-ups. So similarly, these cases which we do dome osteotomy. In this case, we did dome osteotomy. This is also published, case of our stress fractures. But these are some cases which are worth pondering. 37 degrees of valgus. We don't know how much lateral condyle hypoplasia is there. You can see how the patient walks, and this is all we get actually. So we did a Mako-based planning, simple X-rays, CT scans, implant plan, implant sizes, and we cannot have, we planned everything before we went in, and this is what we were getting, upside down rectangle gap. We managed everything before cutting it. and then we executed with the robotic arm, and we got something like this. Ultimately, all these 37-degree valgus papers, cases, managed with simple PS implants. Because of cutting less and knowing more before you go in. Serial follow-ups, same, similarly these types of cases. I won't highlight these cases because this has been selected in one of the international journal of, it's in arthroplasty today, and within a month's time it would be on air. So you can see all these, how we manage difficult cases with minimal bone cuts and getting straighter. So also you can see in this X-ray, one of the X-rays, that there is some lateral laxity, medial laxity. So it gets auto-corrected. And there is again one paper by one of the authors which show that there is some residual laxity which does get corrected, and I researched more, and there are many papers from Japan which say like this. So these are the post-op, and this is the patient. Yes, sir. Patient walking. Let's come to the hips. So in hips, we don't deal with primary cases like as we did today. Somehow we deal with something, patients, kypho, scoliosis, having ankylosing spondylitis, can't walk, absolutely fused hip. We plan meticulously on the robotic platform, version, everything. We use the enhanced platform for this, plan everything, and we execute as we did today. And we did bilateral simultaneously total hip replacements, and we verify the results. We do post-operative CT scans for few patients as it was a part of the study. And these are the cases which we do, bony ankylosed cases. It's not one case, two case, 38 cases. One paper is published and second follow-up is coming. So there is a separate protocol for blocking this. Decoding all this. We do it registration in an en bloc manner, not like we did today. And then it's taken in one segment, and with single cut, with the magic knife, we can cut the neck, and we have it on screen like this, and with a single dimming, you can see the robotic arms takes you there where we planned. So no serial rentograms, no excess, and you just do it. You can see jolly well in this case, once the neck cut is done with the magic knife, just the robotic arm rolls in. It just come, we were just analyzing something here. So robotic arm comes and it will take you there, and you'll have a fine cup in these few tips. In these cases, we do take spinopelvic relationship, do on version 4.0, calculate the anti-version, see all those things, and we verify the results. So these are the patients, same patient, this patient doing walking like this, cycling. Now we forget about the bone loss and find how much bone is left. Like in these cases, we planned with the robot and then put our graft and mesh what we want. And then we did virtual RRM planning. So many things we know. So what I would like to say, there is depth of Lunix safe zones. These are some happy patients, fused hip, right hip, sitting cross leg, he's just jumping like a jumping jack. So happy. This patient, you'll see, abducted. Patient can't enter inside the CT scan. But you see now simultaneously bilateral THR done in the same sitting. So these are some things which we are going better with the robotic arm. We are having less harm to the soft tissues. We have the largest series published by us on RATHR in fused ankylosing spondylitis, fused bony hips. These are some papers of complex primaries done with the robotic arm. These are some papers which shows how robotic arm is not beneficial, navigation is beneficial. So this is again a second paper which we have seen that robot can't work because you need to, things should not be mobile. So there comes the role of image-free systems like navigation. So what I would like to end upon, change is the law of nature. It's coming, already happening in some surgical procedures, telesurgery. Progress is inevitable. Technology is here to stay. Only the forms will become smaller and change with time. Nature's law, those who will embrace the change and those who don't embrace the change will perish and retire. So with this, now I'll also highlight that we have the 3D printer. We do all these printing of the complex cases at our hospital, and we have tie-up with materialized company for the planning, and we have enhanced planning, something like this. Just one more minute. And we plan something like this, and this, in this case, we'll do hemipelvectomy with all these things, and these are some models which we create at our hospital, plan everything before we go in, and we give a good function outcome. Thank you for attending Anup Master's course. On behalf of everybody, I would like to invite you for the today's gala evening, which is going to be grand. a Saregama winner is going to come, and you will have a good time in the evening. Thank you. Ayush sir.